Take V5 and put it mid-scapula, right in that fifth intercostal space. Same space going right around the back. And then take V6 and put it between the spinal cord and the one that you have that's mid-scapula. Run another 12 lead on them. Look for elevation in those leads. Now it's really important, if you do move V4 to V4R, do not transmit these 12 leads, because you cannot write on something you're transmitting, and you're going to screw up any cardiologist if you do so. But it's a good idea to print another one off, write up there that this was a V4R, and then hand it to the nurse or the doctor when you get there. So if we first ran this and we saw elevation in 2-3 AVF, we knew we had an inferior wall. We decided to run another 12 lead. We took V4 and moved it to the right side. And when I did it, I came out with elevation here. This means that this patient is having a right ventricular MI. They're going to be hypotensive, JVD, definitely no nitro or no morphine for these patients. Okay? But make sure you're writing before you go ahead and you give that to anybody. If you're doing a posterior wall, if we take a look here, in V1, V2, V3, we all had ST segment depression. Okay? We could suspect that someone might be having a posterior wall. We move V4R, and then we move V5 and V6 to V8 and V9. And we have elevation on those leads. That means this patient is having a posterior wall MI. And like I said, 50% of all of our STEMIs are missed due to posterior wall MIs. Even the hospitals a lot of times forget to go ahead and do them. They end up in the cath lab. Anybody have any questions on any different types of STEMIs? So we looked at all the different STEMI options, but there's other things that go on in a 12 lead that can cause problems for you, well not for you, but for the patients that you guys are caring for. And one of that is that they have an enlarged heart. They have left or right ventricular hypertrophy, or they have atrial enlargement. And you can see, nice healthy heart here, but enlarged heart, the more the heart, or the harder the heart has to work to push blood throughout the rest of the body, the bigger that the heart muscle itself is going to end up getting. We can see on a 12 lead if someone has large parts of the heart. If we want to start by taking a look at right atrial enlargement. This isn't such a big deal. We don't worry about patients who have enlarged right atria. Usually right atrial enlargement is secondary to right ventricular hypertrophy. What we're going to see is in lead 2, we're going to see tall pointed P waves. Usually they're going to be greater than 2.5 millimeters high, or 2.5 boxes high. But in reality, I mean, there's nothing for treatment. It just gives us a general idea. If we see someone with right atrial enlargement, it would not be uncommon for them to have right ventricular heart failure. We might see pedal edema, ascites in the abdominal area, JVD actually occurring. And this can help us figure out with these pieces of the puzzle what really might be going on with our patients. Then if we see left atrial enlargement, if you look in lead 2, you're going to see a notched P wave, or it looks more like an M, if you will. We generally will see left atrial enlargement, again, secondary to left ventricular hypertrophy, meaning that that left ventricle is having to pump against the systemic vascular resistance pretty hard. And so everything just kind of backs up. It would not be uncommon to see a patient with pulmonary edema if they had left atrial enlargement. Looking at right ventricular hypertrophy, again, the right side is their pulmonary side. We'll see right atrial enlargement, right axis deviation, cor pulmonale or right-sided heart failure, and PE, those types of things are very common anytime we have right ventricular hypertrophy. So what are we looking for to see if someone has right-sided or right ventricular hypertrophy? If you really take a look at V1, that's probably going to be the easiest place. is the R wave itself taller than 7 millimeters? Now normally V1 has a negative deflection. And we always said that if V1 is a positive deflection, it's a right bundle branch block. That's only if the QRS complex is greater than 120 milliseconds. This is going to be a fairly narrow complex, so it's going to be less than that 120 milliseconds. So if we take a look here, and we see this, for the most part, our waves are very, very narrow. So we know it's not greater than 120 milliseconds. But if we look at V1, we've got a tall, greater than 7 millimeters of that R wave elevation. So this patient would have right ventricular hypertrophy. Right ventricular hypertrophy really isn't too much of a big deal. It's the left-sided that becomes more of an issue because that left side is pumping against the systemic vascular resistance throughout the rest of the body. If you take a look here, you look at these and you think, oh my goodness, what the heck is going on? You know, we got to turn down the gain on our QRS gain because it's way too big. No, that's just showing that they've got hypertrophy. So what are we going to do to determine? Well, we're going to look at V1 and V2, and we're going to see which, between those two leads, which is the deepest S wave. Then we're going to look at V5 and V6, and we're going to say, which is the tallest R wave? We're going to count the boxes. We'll add them up. If they're over 35, and the patient's over 35 years of age, that would indicate that this patient has left ventricular hypertrophy. Now, this is a pretty controversial method to determine it, but it's the best one that these patients can come up with. Who's going to have left ventricular hypertrophy? Well, patients that have high blood pressure, hypertension, pulmonary hypertension, patients who have heart disease, or someone who is actually suffering from an MI at that point. If we look here, and I say, okay, V1 and V2, which one's got the deeper S wave? And I can pretty much say that V2 has the deeper S wave. I go to V5 and V6, say which one's got the taller R waves, and I would probably go with this one, V6. I count all the boxes and I add them together, they total over 35. This patient does have left ventricular hypertrophy. I would not be, it would not be uncommon at this point to see a history of heart disease in this patient. I might see some pulmonary edema in this patient. Maybe even to the point of seeing some pedal edema start to build up. All right, the last one we're going to look at is the different electrolytes we'll have on a 12 lead, and then the STEMI mimickers, the ones that you guys get caught up when you see, you're like, oh, this is a SC segment elevation, this is a STEMI, when in actuality it's not. So potassium is the first electrolyte that you guys are going to see make a difference on your 12 lead. Potassium does a couple things. It allows the heart rate, slows the heart rate in vagal conditions. It protects the heart from getting too excited, and it allows the heart to beat fairly fast at a very organized rhythm. So the first thing we look at is hypokalemia. Normal potassium levels are 3.5 to 5.5 milliequivalents per liter. It doesn't really matter if it's too high or too low, but generally people who have very low hypokalemia have the likelihood of going into cardiac arrest and going into VFib on you. Some of the things that you might see on your 12 lead, if you're looking for it, is that you're going to start to see this U wave back up onto the T wave. So normal is A, we see a nice complex here. B, we start to see our T wave flatten out a little bit. In C, it looks kind of bumpy. It looks like our T wave has gotten bumpy. When what's happening here is the U wave is starting to come up on that T wave. And it gets worse and worse until the U wave ultimately overtakes the T wave. That is one of the things you will see if someone is hypokalemic. Who is hypokalemic? Well, someone who's on diuretics, someone who's been sick, nausea, vomiting, diarrhea. They've got muscle weakness. They're not having proper intake. They're urinating a lot. Other things to be watchful for if someone is hypokalemic, it would not be uncommon for them to go into a heart block, even them go into AFib. What do they have to do? Well, potassium supplements for the most, otherwise, or if they're sick, Zofran or something that's going to keep them from vomiting or diarrhea. Now, someone who has hyperkalemia, you definitely will see this also. It depends on how high it actually is for you to see, but serum levels above 5 milliequivalents are usually caused by renal failure. These people are retaining potassium. Other people take diuretics that are potassium-sparing diuretics. Now, when a patient gets to 7.5 to 8 milliequivalents of potassium, their P wave will generally disappear, and it looks more like a junctional rhythm that you're seeing. The higher we get, we'll start to see sine waves, usually at 9 milliequivalents. So we start off with mild. T wave starts to become pretty peaked. Okay? We see PR intervals start to flatten out a little bit. When we get to the moderate, our P wave is gone. But look at our T wave. It's even getting it's about as tall as our whole QRS complex. And then when they get to severe, this is where we need to be very cautious because they will go into VTAC or VFib. You get to see what they call a sine wave, and it looks more like an idioventricular beat. These patients generally will have bundle branch blocks, they'll have extreme right axis deviation, and they'll go into VFib, and you're going to end up coding them. Can we do anything for someone who is hyperkalemic per our protocols? Not right now, we can't. You guys will be getting sodium bicarb if we ever get these darn new protocols off the table. Gracious, who knows? Maybe by 2020 when we finally implement the 2010 education standards. So, yeah, I'm getting nasty about it, but. We're going to have sodium bicarb for crush injuries. We're going to have it for tricyclid antidepressant overdoses, cardiac arrest, hyperkalemia. And we're going to give 50 milliequivalents for a patient. Now, normal dose is 1 milliequivalent per kilo, but our physicians decided just to stay with 50. That's what an amp is, and they thought, well, that'll be good enough. But that will at least be able to help out, reduce some of the hyperkalemia. Currently, right now, some of our doctors are giving orders for a medication if they see hyperkalemia in a patient. And that is albuterol. Albuterol can cause a shift in potassium ions in the serum level enough to prevent them from coding until they get to the hospital where they're going to get the calcium gluconate, insulin, dextrose, and things like that to go ahead and reduce the potassium levels within the body. So don't be surprised if you tell the doctors you've got someone who's hyperkalemic, they were at dialysis, they're in renal failure, whatever the situation is, and the doctor says, you know what, go start continuous neb treatment, just albuterol on these patients. And that will at least start lowering some of the hyperkalemia. Other things to look at are QT interval. The QT interval is from the start of the Q wave to the end of the T wave. Now, there is a nice algebraic formula that will actually determine what the proper QT interval is. If you remember looking at the numbers, you saw QT and QTC, and it really is based off the patient's heart rate and what's going on. But the easiest thing for you guys to do to take a look at is take a look at your R to R. Is my QT interval more than halfway in my R to R interval? If it is, then you've got a prolonged QT interval. That can be problematic because we're worried about these patients having RMT phenomenon, meaning repolarization and depolarization of the ventricle at the same time, causing my patient to go into VFib. Some of the medications that you guys get, one of them being amiodarone. You've got an amiodarone drip going on your patient, and you notice that QT interval is getting longer and longer. Stop the amiodarone drip. Prolonged QT interval is one of the side effects of amiodarone. Tricyclics. Someone, we see a lot of our vets on tricyclid antidepressants. That seems to be the drug of choice given out by the docs and the VA. Those that are on digitalis also, you might see prolonged QT intervals. Some of the other ones, left ventricular hypertrophy, or maybe even a patient who's hypothermic. Yeah, and as I said here, this is what we're talking about. The QT interval does vary with the heart rate, and there is that equation, but if you guys just follow with the R to R interval and the halfway point, it's going to be a lot easier for you. But these patients could have syncopal episodes. You know, they can't understand why they're constantly passing out. It could cause them to die all of a sudden or even go into torsades. Now, when we get to torsades, with the protocol, you guys will have NAG sulfate as one of our new medications that will be given. Yeah, we're really loading you guys up with new meds. But we'll be given that for torsades as well as eclampsia and respiratory issues. One of the other STEMI mimickers that people take a look at is the effect of digitalis on a 12 lead. People will look at this and say, oh, this person's got ST segment depression. No, they actually don't. It's just the effects of digitalis. We will usually see this in V6, and it looks like someone just went and scooped out, took a little hand and scooped out that ST segment. And that's called a digitalis effect. Sometimes you'll see a down-sloping effect in V6, but next time you have a patient who's on dig and you got them on the monitor and you run a 12 lead, take a look at V6 and you should be able to see some of the difference. Another STEMI mimicker is pericarditis. Now, pericarditis is very scary and it's also very painful. It does mimic an MI. You know, the sac of the heart itself is inflamed due to some type of virus, but it's affecting the walls of the heart itself. And it looks like this patient has major ST segment elevation. Signs and symptoms, very similar. I've got crushing chest pain or sharp chest pain. I'm short of breath. The thing, though, about pericarditis versus regular MIs is that this patient is going to feel better sitting up and leaning forward. If you ask them to lay down, it's probably going to hurt more. So stuff does make it better or makes it worse. Remember, if it's cardiac, nothing's going to make it better and nothing's going to make it worse. Pericarditis can last for hours and even days. And a lot of times, every time they breathe, it is extremely painful. Nitro will not go ahead and relieve pericarditis. And if you actually listen and do heart tones on this patient, you might hear the rub of the pericardial sac around the heart, almost kind of like the friction rub that you would hear for pleurisy. When we take a look here, and we look at our ST segment elevation, a lot of times if it has that concave instead of the convex, which is upside down, the frown, but the happy face, if you can see that concave, usually means that it is not cardiac related. If the smiley face would be a frown, then we might assume that it would be cardiac in nature. The other thing is all leads are up. We see elevation everywhere. So we take a look at this and we go, oh my gosh, holy buckets, look at the ST segment elevation everywhere. This patient is going to die. And here we've got the smiley face, we've got a smiley face there, kind of there, all the concave. And this patient just has pericarditis. Now, it doesn't, don't take away the fact that this patient isn't suffering, because they definitely are, but it's not cardiac in nature. Can you guys make the determination if a patient has a pulmonary emboli pre-hospital? Most of the time, we can't. We can say, well, we're cardiac arrest, the guy's purple from the nipple line up, absolutely, he's got a PE. A little bit too late at that point in time. But we are using more and more of our tools to make the determination if a patient does have a PE. First of all, history, sharp chest pain, a sudden onset of difficulty breathing. Those are two big signs and symptoms right there of PE. I've been sitting for a long period of time. I just got off the plane. I just had surgery. I I'm on Coumadin, but I ate a whole lot of lettuce with vitamin K or greens with vitamin K, things that could go ahead and increase the ability of having a clot. Okay, so we can suspect that they might be having a PE based off of signs and symptoms. How about one of your other diagnostic tools? You've got capnography. Capnography, if you put that on, might have a notched plateau. Remember, you have your phase 1 where they're going through and starting their exhalation, and we start to see the plateau, and all of a sudden we see the little divot in the plateau. That may indicate that a patient has a pulmonary emboli. So there's two ways to suspect. Then there's the final way that you can use your 12 lead or your regular monitor to see if a patient is having a pulmonary emboli. Sometimes when you print out your 12 lead, and it'll actually print out suspect respiratory, suspect pulmonary emboli. And it's based off the S1Q3T3 pattern, meaning that S1, in lead 1, we have an S wave that's different from leads 2 and 3. Q3 means in lead 3 I have a Q wave, whereas in lead 1 and lead 2 I don't have a Q wave. And T3 means I have an inverted T wave in lead 3, but I don't in leads 1 and 2. Put that in conjunction with right axis deviation, right bundle branch block, possible right atrial enlargement, right ventricular hypertrophy, and you got almost all the evidence you need right then and there to diagnose this patient with a pulmonary emboli. All right, one of the last, is it the last? Yep, the last STEMI mimicker that people really get hung up on, and that's early repolarization. Early repolarization is very, very common in our younger people. Now remember, we're looking for the J point. So if we go ahead, P wave, QRS, here's our J point. This is classic early repolarized. It comes all the way down and it goes back up, and then that's where our J point is, because we see the change in direction. The other thing that we're looking for now is the J wave, and it's this little notch. It starts to come down, and before it can make its way back down to the isoelectric, we see this little hiccup, or this little notch. That notch is telling us that the heart is trying to repolarize earlier than it should. And like I said, for the most part, it's not a big deal, especially in our younger people. Other definitions you'll see here, if you take a look, it's got this nice little notched coming down. It doesn't quite make it, and it does a little hiccup or this little notch right on top. And it is very hard to see when you're taking a look at it. A lot of times you're going to need to see, you know, to enlarge it a little bit to make the determination if we have any early repolarization. But early repolarization is fairly harmless. Well, it is harmless, but it is a STEMI mimicker. People usually will say, oh, it's elevation when it's truly not. All right, anybody have any questions? A lot of information today. Gives you a deeper insight into what really is going on with your 12 leads, different things you might suspect with your patients, and instead of just writing them off, well, they got chest pain or they don't, I'm 5 minutes to the hospital, but take a look at really what could be going on with your patients. Alrighty. Here is your quiz. Can you shut this off? Do you know how to shut that off? Oops. Just one of you left?